Welcome to NSG 327, Mental Health Nursing 2, Study Session 1, Recognition of Major Disorders Occurring in Childhood and Adolescence. Introduction. This study session explores a number of issues relating to the recognition of major disorders occurring in childhood and adolescence. It starts by helping you explore the subconcepts of childhood disorders and understand the difference between the disorders. Learning outcomes for study session 1. When you have studied this session, you should be able to 1. Identify specific syndromes of childhood and adolescent psychiatric disorders. 2. Define mental retardation. 3. Identify the different types of conduct disorders. 4. Describe the group of disorders known as autism spectrum disorder. 5. Describe attention deficit disorder. Child and adolescent mental disorders. Childhood and adolescent psychiatric disorders are types of mental illness which occur in childhood and adolescent age group. A World Health Organization committee recommended that children be assessed on 4 dimensions: clinical psychiatric, syndrome, intelligence, organic factors, and psychosocial factors. Classification and diagnosis of childhood disorders. Externalizing disorders characterized by outward directed behaviors like non-compliance, aggressiveness, overactivity, impulsiveness includes attention deficit or hyperactivity disorder, conduct disorder, and oppositional defiant disorder. More common in boys. Internalizing disorders characterized by inward focused behaviors like depression, anxiety, social withdrawal, and includes childhood anxiety and mood disorders, more common in girls. Clinically, children show the same range of anxiety disorders, psychosomatic disorders, and psychosis as those found in adults. The vast majority can be divided into 2 groups. 1. Children with predominantly neurotic symptoms. These children may suffer from anxiety, phobias, shyness, sleep, and appetite disorders and tics. Most grow up to be stable adults. 2. Children with predominantly conduct disorders, stealing, aggression, lying, overactivity, truancy. These children have poor prognosis in adult life with higher rates of crime, alcoholism, psychiatric admission, and poor work record. Children with behavioral disorders are usually disturbed at home or at school. Only in severe cases are both. Boys have twice as much as girls and also exhibit conduct disorders more often. Specific syndromes of childhood psychiatric disorders includes 1. Nocturnal enuresis. This is more common in early years. At 14 years of age and above, the problem drops to 1 in 35. The problem is more common in males of below average intelligence living in poor social conditions. It is associated with a strong family history. 5% of cases are caused by urinary infections. Other cases may be neurotic. For example, regression after birth of a younger sibling. Yet other cases may be developmental. 2. Encopresis. This involves soiling rather than enuresis. It is usually characterized by retention with overflow. Children with this problem are often of normal intelligence. The problem may be neurotic or developmental. Treatment tends to be unrewarding. However, 50% of children experience spontaneous recovery in 2 years, and almost all recover before adult life. 3. Stuttering. There are two groups of children who may suffer from stuttering. The first are dull, often from poor social backgrounds and having suffered a birth injury. The second group tends to be of average or above average intelligence and come from ambitious families with anxious, obsessional mothers. In both groups, the anxiety engendered by stuttering may lead to secondary neurotic disorders. Speech therapy is helpful. 4. Early childhood autism. This is a form of childhood psychosis beginning from birth or in the first 3 years. It should not be confused with schizophrenia, which is rare and occurs later in childhood. Autism is now generally agreed to be an organic condition, although formerly it was attributed to upbringing or the parents' personalities. The central defect is a difficulty in comprehension and the use of language. It is rare, occurring in about 1 in 2,000 school children. 3 boys are affected for every girl. The parents of autistic children tend to be intelligent. The symptoms comprise lack of speech, problem of comprehension, mutism or abnormal speech. With echolalia and the avoidance of the personal pronoun and a monotonous mechanical voice, autistic children have difficulty in copying movements, flicking movements of hands, spinning and jumping movements. They often exhibit a paradoxical response to sounds. They are resistant to change of routine. They are generally socially aloof, live in a world of their own. They often have tantrums. When testable, only 30% of autistic children have an IQ above 55. A third of autistic children develop fits in adolescence or adult life. Differential diagnoses include deafness, partial blindness, elective mutism. This is a neurotic disorder in which the child, usually male, is persistently mute in selected circumstances, for instance, at school. Most are solitary and over-dependent on their parents. Mental subnormality. The prognosis is poor. 60% of autistic children remain unchanged. Only 15% find open employment. The prognosis is slightly improved in the children with a higher IQ. School refusal. School phobia is relatively rare. Peak age for its occurrence is 11 to 12 years. It is often precipitated by change of school or illness in parents or grandparents. It is found most often in boys and children of intelligence average. It is more common in well-behaved children doing well at school, who are often anxious and shy. The problem is associated with increasing anxiety, often with abdominal pain and vomiting, culminating in refusal to go to school. It is quite distinct from truancy. The mothers of children suffering from school refusal are often overprotective and subject to depression. The problem is generally due to separation anxiety rather than fear of school. The treatment may necessitate admission to a residential school or temporary separation from parents. 5. Tics, habit spasms. Tics are sudden, brief, often repeated movements involving a group of muscles. They have no purpose but are usually based on purposive movements, such as blinking, head shaking, and coughing. The most common tic is eye blinking. Tics decline in frequency from head to feet. They are found in 10% of children aged 6 to 7. They are twice as common in boys. There is often a family history of tics. Children with tics are commonly of average or above in intelligence and well-behaved. They are often associated with emotional disturbance, sometimes with speech disorders, obsessions, and hypochondria. The prognosis is good. Most tics are short-lived. The others spontaneously generally improve in adolescence. The very rare Gilsey-La Tourette syndrome comprises multiple severe tics with compulsive swearing and has a poor prognosis. 6. Hyperkinetic syndrome. This syndrome is characterized by overactive from an early age. Sleeping little, wearing out clothes and shoes, and an inability to sit still. Children with this problem are dangerously impulsive, distractible, with a short attention span. They exhibit daydreaming and lack of perseverance. They are excitable and have frequent temper tantrums. The syndrome is sometimes associated with organic brain disease, epilepsy, or a low IQ, but often it is not. It's 5 times more common in boys and is not a rare condition. Children with the syndrome show an excess of minor neurological abnormalities, for example, in coordination and clumsiness. Parents generally have above average rates of personality disorder and alcoholism. Children have similar risk in adult life. The prognosis is poor. Specific adolescent psychiatric disorder. The adolescent years are a time of major change for the individual. A growth spurt in early adolescence, 13 to 14 years of age for boys and 10 to 12 years of age for girls, is followed soon by sexual maturation. The adolescent becomes physically different in a very short time and is faced with strenuous psychological adjustments to these changes throughout adolescence. Intellectual maturation progresses. Although IQ does not continue to rise, there is an increase in logical and abstract reasoning. Emotionally, the adolescent generally strives for maturity and independence, particularly from their parents, but finds it difficult to give up the security and dependence of home and parents. The ambivalent feelings lead to frequent inconsistencies in behavior. This is between states is accompanied by mild feelings of depression and emptiness in 50% of adolescents. Erikson describes adolescence as a time of identity crisis when the individual has to decide who she or he is, what she or he can do, and what she or he will make of her or his life. Social pressures are plentiful. He or she must learn many new roles at this time, changing from school to work, from child to parent. There is much pressure to conform to the peer group, whose standards may differ sharply from those of parents. It should be emphasized that although minor conflicts are common, serious and persistent difficulties between adolescents and their parents are rare in general. In general, rates for psychiatric disorder are higher than those for adults. Those who are disordered often communicate poorly with their parents. As with children, adolescent disorders may be classified as behavioral conduct or emotional disturbance. Many adolescents show both. 1. Neurotic disorders. As adolescence advances, the symptoms are similar to those seen in adults. Depression and anxiety are common, the content of thoughts being the normal problems of the age group, but these are magnified. Appearance, sexual problems, status with friends, and frequent preoccupations. School refusal in adolescence may be a sign of severe neurotic difficulty. 2. Conduct disorder. This disorder is more common in boys from disturbed families. It is characterized by antisocial behavior in a wide range of settings and poor relations with others. It should not be confused with delinquency. The number of delinquents showing psychiatric disorder is not much higher than average. Conduct disorder is often associated with reading difficulties. Anorexia nervosa. This problem is a common and increasing disorder of adolescent girls. The disorder generally begins with the wish to diet and feeling fat. It is characterized by progressive weight loss associated with early amenorrhea. The patient quickly becomes emaciated but maintains she feels normal and looks normal and claims to be eating adequately. The disorder often includes self-induced vomiting and excessive purging carried out in secret. There may be intermittent overeating, bulimia, especially after treatment. Patients are very resistant to accepting treatment. The disorder is potentially serious. In those whom the conditions last for 10 years, the lethal mortality may be 10%. Poor prognosis is associated with disturbed body image. The weight of patients with the disease typically falls to 30 to 35 kg. Best regarded as a phobic avoidance of adolescent weight gain. and the physical and psychological changes of puberty. The treatment target is to enable the patient to gain weight assisted by good nursing, high doses of phenothiazines, and psychotherapy. Adolescent depression are almost always due to a combination of factors like issues due to background and family issues. In boys, depression is more likely to be acted out with aggressive behavior such as risk-taking, substance abuse, confrontations with authority, but in girls, it presents as classic symptoms. First major episodes are during adolescent years, often between the ages of 15 to 19. In depression, one of the first cues is a large drop in school performance, drug or alcohol abuse, lack of concentration, restlessness or hyperactivity, antisocial behavior, extreme fatigue, sleep all the time but are not rested, and lastly, suicide. High risk teens make their decisions after a disaster has occurred. Breakups, academic failure, fights with parents, or run in with authority. Suicide warning sign includes, but not limited to, constant insomnia, may be on computer at all hours of the night, changes in behavior, dropping grades, etc. Alcohol is involved in half of all suicides. Seriously impairs judgment. Suicide is not chosen. It happens when pain exceeds resources for pain. Boys are most successful in committing suicide. Childhood schizophrenia is a group of disorders of thought processes characterized by gradual disintegration of mental function, occurs in adolescents or as young adults. 1. Obsessive compulsion disorder often begins slowly and gradually during their childhood or teenage years and increase in severity as time goes on. Though a chronic disease, there will be periods of reduced symptoms followed by flare-ups, often stressful times in person's life. Relief is only temporary. Usually both obsessions and compulsions occur together. Recognized thoughts or behaviors are irrational, but are compelled to continue them against their will. 2. Autistic disorder is mostly prevalent in boys, identified not later than 3 years of age. Child has little eye contact, few facial expression, doesn't use gestures to communicate, does not relate to parents or peers, lacks spontaneous enjoyment, apparent absence of mood and emotional affect, cannot be engaged in play to make believe, repetitive motor behaviors such as hand flapping, body twisting, or head banging may improve as child acquires language skills. 3. Attention deficit disorders is characterized by patterns of inattention, hyperactivity, and impulsiveness, often diagnosed when a child starts school. Signs and symptoms include inattentive behaviors, hyperactive or impulsive behaviors, fidgets, often leaves seat, can't play quietly, cannot wait for turn, speech is unimpaired, but the child cannot carry on a conversation. He interrupts, blots out answers before the question is finished, and fails to pay attention to what is said. Mood may be liable, even to the point of verbal outbursts or temper tantrums. Engaged in impulsive acts such as running into the streets and jumping off of high objects. 4. Conduct disorder is characterized by persistent antisocial behavior in children and adolescents that significantly impair their ability to function in social, academic, or occupational area. Symptoms are clustered into 4 areas: aggression to people and animals, destruction to property, deceitfulness and theft, serious violation of rules and the law. Other symptoms are decreased self-esteem, poor frustration to tolerance, temper often out of control, early onset of sexual behavior, alcohol and substance abuse, smoking, risky behavior. 5. Oppositional defiant disorders consist of an enduring pattern of uncooperative defiance and hostile behavior towards authority, figures without major antisocial violations. A certain level of oppositional behavior is common in children and adolescents. Oppositional defiant disorder is diagnosed only when behaviors are more frequent and intense than unaffected peers, and cause dysfunction in social, academic, or work situations. 6. Tic disorders involve sudden, rapid, recurrent, non-rhythmic motor movement or vocalization. Examples of complex vocal tics are coprolalia, use of socially unacceptable words often obscene; palilalia, repeating own sounds or words; and echolalia, repeating the last heard sound, word, or phrase. Stress and fatigue exacerbate tics. Tourette's syndrome and multiple motor tics and one or more vocal tics may occur many times a day for over a year, usually identified by 7 years of age. 7. Elimination disorders can be in form of encopresis or enuresis. Encopresis means repeated passage of feces into inappropriate places such as clothing or floor by a child who is at least 4 years of age, either chronically or developmentally, often involuntary, but can be intentional. Oppositional defiant disorder or conduct disorder associated with constipation that occurs for psychological, not medical reasons. Enuresis means repeated voiding of urine during the day or night into clothing or bed by a child at least 5 years of age. 8. Eating disorders. Eating disorders come in form of anorexia or bulimia. The distinguishing factor of anorexia includes an earlier age of onset and below normal body weight. The person fails to recognize the eating behavior as a problem. Clients with bulimia have a later age at onset and a near normal body weight. They usually are ashamed and embarrassed by the eating disorder. Anorexia nervosa is a life-threatening eating disorder characterized by the client's refusal or inability to maintain a minimally normal body weight, intense fear of gaining weight or becoming fat, significantly disturbed perception of the shape or size of the body, and steadfast inability or refusal to acknowledge the seriousness of the problem or even that one exists. Has experienced amenorrhea for at least 3 consecutive cycles, complaints of constipation and abdominal pain, cold intolerance, hypotension, hypothermia, bradycardia. Intravascular volume is decreased, less blood to pump through heart, also due to excessive exercise. Urea is formed in the liver and is the end product of protein metabolism. In anorexia, the body has already used fat for energy. It is now breaking down muscles for energy. The reason for the elevated bone: normal levels 10 to 20 milligram. Decreased albumin, normal levels 3.5 to 5 gram. Measures amount of protein in the body. Albumin is a protein formed in the liver. Albumin tests are a great indicator of nutritional status. Leukopenia and mild anemia, not enough food and nutrients to replenish cells, has a preoccupation with food and food-related activities, diagnosed between 14 and 18 years of age, pleased with their ability to control their weight and may express this. As the illness progresses, depression and liability in mood become more apparent, isolate themselves and believe peers are jealous of their weight loss, and believe family and healthcare professionals are trying to make them fat and ugly. Clients who use laxatives are at a greater risk for medical complications. Autonomy may be difficult in families that are overprotective or in with enmeshment. Lack of clear boundaries exists. By losing weight, these clients have some control in their lives, have body image disturbance, can be very difficult to treat because they are often resistant, appear uninterested, and deny their problems, can be divided into 2 groups. Restricting subtype: lose weight primarily through dieting, fasting, or excessively exercising. Binge eating and purging subtype: engage regularly in binge eating followed by purging. Engage in unusual ritualistic food behaviors, refusing to eat around others, cutting food into minute pieces, not allowing the food they eat to touch their lips. Excessive exercise is common. Bulimia nervosa is characterized by recurrent episodes, at least twice a week for 3 months, of binge eating, followed by inappropriate measures to avoid weight gain. such as purging, vomiting, laxatives, diuretics, enemas, or emetics, fasting, or excessively exercising. Engaging in binge eating, secretly binging or purging episodes are often precipitated by strong emotions and followed by guilt, remorse, shame, or self-contempt. Recurrent vomiting destroys tooth enamel, has dental caries and ragged or chipped teeth. Bulimia is typically diagnosed at 18 or 19. Clients with bulimia are aware that their eating behavior is pathologic and go great lengths to hide it from other clients with a comorbid personality disorder tend to have poorer outcomes than those without. Clients are often focused on pleasing others and have a history of impulsive behavior, such as a substance abuse and shoplifting, as well as anxiety, depression, and personality disorders. May be underweight, overweight, but are generally close to expected body weight for age and size. Appear open and willing to talk. Initially pleasant and cheerful as though nothing is wrong. Summary of study session 1. In study session 1, you have learned that childhood and adolescent psychiatric disorders are types of mental illness which occur in childhood and adolescent age group. Specific syndromes of childhood psychiatric disorders include nocturnal enuresis, encopresis, stuttering, early childhood autism, school refusal, tics, and hyperkinetic syndrome. 3. Common specific adolescent psychiatric disorders and neurotic disorders, conduct disorder, eating disorders, adolescent depression, schizophrenia, obsessive compulsion disorder, oppositional defiant disorder, tic disorders, elimination disorders. We have come to the end of study session 1.